what's so fascinating is what is said and what the subtext is. And so, for example, if I'm in a family meeting and oncology or whoever is offering a treatment and says that studies show someone will live an average of 5.8 months longer or something, one of my questions is always, is the person before you someone who would have been included in that study? Would they have met the criteria for the study? Because from a logical perspective, we have to interpret data based on the person in front of us. And if the person in front of us would have been too sick to get that treatment, then the results don't apply to them.
Welcome to the Unspeakeasy podcast, the podcast formerly known as The Unspeakable. I am your host, Meghan Daum. My guest is author and palliative-care physician, Dr. Sunita Puri. She's a listener favorite. I don't know what that says about you guys, since her subject is death, how to think about it, how to get through it, how to see others through it. Sunita cares for dying patients, of course, and she writes frequently about her work and about what we can do to try to have a good death, whatever that means. She was last on the podcast 2 years ago talking about CPR and how its overuse can hurt patients. She is back to catch us up on what's been on her mind since then, including changing attitudes about end-of-life choices and physician-assisted suicide. We also talk about what we can all do to make sure our wishes are known and respected without having to get a DNR tattoo on our chests. Apparently people do that. This is a heavy topic, but as always with Sunita, it doesn't feel heavy. It's actually kind of fun. I learned a lot as always, and I hope you will too. So here is my conversation with Dr. Sunita Puri. Sunita Puri, welcome back to the podcast.
Thank you so much for having me, Meghan.
You were here last September talking about a couple of your recent articles, notably a Wall Street Journal piece about this notion of a good death and the way dying at home has this romantic valence to it that is often just that. It's romantic. And that was a great conversation. You wrote recently about similar ideas from a slightly different angle in the New York Times. You had a piece back in June that came about after watching the cable series Dying for Sex.
So a friend of mine told me that I should watch this because it was pretty explicit about dying. There was a palliative care social worker in it, and it showed the journey of the main character named Molly from the time that she got informed that her breast cancer was back and it was metastatic, all the way to her death in hospice. And my friend just thought it would be an interesting show for me to watch, being that this is what I'm immersed in all the time. And so I watched it. And
I would think it would be the other way around. If it'd be like, if people would be like, don't you want to watch this show about a workaholic podcaster and
this
frustrated
is why
writer?
I come home, watch Breaking Bad all the time.
Yes, right. If you were a drug dealer, it'd be like, oh, this is another day at the office. But okay. Anyway,
Exactly.
So you watch this show.
Yes. And I think what struck me so much was this idea that Molly had certain things that she wanted to experience in life and didn't act on them until she knew for certain that she was going to die from this disease. And for those who haven't watched the show, it's actually based on a true story of a woman who was in her early 40s who had breast cancer, went into remission, and then was diagnosed as having it back metastatic. And she was in a pretty unfulfilling marriage and decided actually to leave her husband to explore ways to gain the sexual fulfillment that had eluded her whole life. She has a history of childhood sexual abuse, and that had prevented her from ever having an orgasm. So she went in search of that. And you see in the early appointments with her doctors and the palliative care social worker that having an orgasm with another person was high on her list of what she wanted to be able to do.
So that was on her bucket list.
Yes.
So to speak.
And I think the show raised a couple of issues for me. One is something I see often, which is in medicine, in that realm, we really prioritize starting to talk about what matters to someone at the point where we know they're facing a serious illness that's likely to take their life. We don't really talk about these things as much earlier on when people are sick, but once we know for sure that someone is going to die of their disease, and we still do a bad job of it, as I've talked about before, but that's really when any discussion of what matters to someone, who matters to someone, what doesn't matter to someone, that's the time when people are asked most directly about it. And that's the time when people are forced to think about what brings their life meaning, what doesn't. And it's something that I find a real barrier to living a meaningful life is waiting until we know for sure we are going to die from something to start thinking about these questions. And so her dilemma or her experience in that series, which led to her making decisions she's wanted to make for a long time, was kind of a jumping off point for me about how common this is that, I encounter in my practice, and what could I kind of help people do to try to think about these things earlier on in life in a very intentional way.
Okay, well, putting aside for a second this question of how much libido one would have if one were having late stage cancer and getting some kind of treatment. Good for her. You have some remarkable insights in your piece. You say, you talk about, this character Molly, and you say her body still burns with desire and she has a support system that helps her achieve what she wants. But
Yes.
You say that wasn't the case. And you go on to mention a number of your patients, including one who dieted for her whole life and figuring she would eat in her later years. And then she ends up with esophageal cancer and she can't swallow. This is really tough stuff. So talk about some of the patients that were coming to mind.
Absolutely. So the one that kind of formed the lead of the piece was a gentleman who was just trying to get to the finish line of retirement. He and his wife were going to take a European cruise. That thought kept him going through his last week of work or last year of work. But he had symptoms coming up the whole time of nausea, bloating, abdominal pain, and he kind of pushed through it, only to get the diagnosis of metastatic cancer after he retired. And I'm going to just say as a side note, Megan, I've actually seen this pretty often. People are just waiting to retire and boom, they get sick with a very serious diagnosis.
That happened to my mother, actually, now that I think about it. She was just a few years after retirement and she was living the life that she had dreamed of. And a year and a half, 2 years into it, stage 4 cancer.
Exactly. And I didn't know that her retirement had been so close to that experience.
I just thought of it now, actually, now that you're saying that. So this is common. It's obviously not causal. It's got to be correlative. People, I guess, like from an actuarial standpoint, people are going to retire at a certain age, and that's going to be an age where you're more likely to get a cancer diagnosis than when you're graduating from high school or something.
Although now there's all these people in their 20s, 30s, and 40s with horrible.
Right. Yeah. I want to talk about that. But okay. So you're finding that people, are you like wanting them to just sort of live their lives more fully earlier on, or what is your message around this?
So I think a couple things. One, so with that patient and others, the amount of regret that I've run into when I'm talking to people is enormous. And it's not regret about, I should have worked harder. I should have made different decisions about my professional life. It's almost always things like, I should have told this person I loved her. I shouldn't have been so afraid to pursue a dream. I regret the person I became when I was deep in my alcohol addiction. That sort of really big, heavy spiritual stuff about the choices people have made, what resulted from those choices, and how it inflicted harm on themselves and others. And there were also people I've come across who said, I should have taken that trip. Why did I postpone this? And my patient who got gastric cancer was one of those people. And so I think that one of the things I talked about in the piece is instead of posing a scenario, like if you had a year to live, how would you live differently? The problem I have with that setup is that we don't know what any given day is going to bring to us. Right? Death is by definition unpredictable. Illness is unpredictable. One day you're okay and the next day you are not. Even with symptoms creeping up, once you have the label, your life is never the same. And so projecting that you have definitely 1 year left to live and what would you do, to me seems like an artificial setup of probing really important questions. So instead of that setup, I suggest people do things like think about the last 6 months. Who or what brought you joy? Who or what didn't? What do you regret about decisions you've made over the past 6 months? What were you proud of yourself for in the last 6 months? So it's still using a time frame, but it's not projecting forward, it's projecting backwards in a way that you can then inform some of the choices you make and inform the sort of person you wish to be for yourself and for other people moving forward. Because I think when people are told, okay, you have a year to live, it just, the mystery of illness and the choices you might actually make when you are sick, they get almost like idealized. People will say, oh yeah, I'll quit my job if I know I have a year to live, but you don't know how much time you have. So all you can do is look at the now and what has led to the now and see if what changes you want to make, if you're content with how things are right now, and what you really want your life to look like.
But have you had patients who say, actually, I hate everything about my life. I hate my partner. I hate my job. I hate my house. I hate where I live. I just want to like ditch it all and, hit the road in an RV. And what do you say to somebody like that if they're sick?
Yep. So I have had people say to me that, okay, I have this cancer. I just want to travel the world. I don't want chemo, really. And so my job is not to say, you go, I'm all in. My job is to explore that. Any big sudden changes in what people want, and even subtle changes in what people want, my job is to explore and to try to understand in this sort of situation, what is the reason behind the drastic change? So for this particular patient who had metastatic breast cancer, in my practice, not Molly in the show, she was very insistent. She said, I saw a friend of mine die from cancer. I saw what chemo did to her, and I don't want that for myself. But what I had to do was actually explain to her that the cancer her friend had and the treatment for that was much more toxic than the treatments that were going to be offered to her. And once we talked about that, I'm just going to say it here. You heard it first. This palliative care doctor actually referred her to oncology to hear about her options. And so the art of exploration is something I love about my practice because you get to really understand what's pulsing beneath people's decision-making. What is the motivation here? And it's never my job to say you're wrong, but I also did talk to her about the symptoms she might face if she's traveling the world. Who would be there to help her through those things?
Right.
I had another patient with metastatic colon cancer who said the same thing to me that, he was younger. I think he was 45, and he had a very stressful job. And he just said, I regret that I pushed myself into a career that at some level I never wanted. So I'm going to quit and live off my savings. And how can we make this happen? Can you prescribe me morphine if I'm in Austria? And so we had to have a talk about me validating a lot of the things that were leading up to this drastic decision for him, but me also being pretty explicit about the complications of something like colon cancer. For example, a bowel blockage, what we call a malignant bowel obstruction. If you have something like that and you're on a beach, wherever, That is an emergency sort of situation. You don't want to die like that. It's extraordinarily painful. It causes nausea and vomiting that just won't relent. And so part of informed consent around decision-making is me kind of saying, I hear you and I want to support you, but I wouldn't be doing my job if I didn't explain to you some of my worries, given my experience seeing these sort of situations play out.
So what did this man do ultimately?
So he ended up getting some treatment.
Was he able to travel?
He was able to travel because the treatment actually helped reduce some of his disease burden. And when he traveled, we made sure that he had all the meds he needed, and he would go away for like 4 months at a time and come back, and he would get more treatment after that first cycle, get scanned. So he wasn't sticking to a traditional treatment regimen, but we were trying to accommodate his desires and trying to minimize the effects the colon cancer might have on his life. And we talked explicitly about the toxicity of chemotherapy, his oncologist and I. And he had some lines in the sand for himself that if he developed a big complication like a malignant bowel obstruction, that he did not want any further treatment and he just wanted palliation. If he, developed horrible neuropathy in his arms and legs, that as a complication of chemo, he would not want to continue living that way. So I think in addition to helping people with the bigger picture of what they want to do, there's also this art of what are your lines in the sand? And that's the stuff that gets lost when we hear people say, I want to just quit everything and move to Paris and live out my days. There's a lot more subtlety to different types of decision making in that journey. And that's what I really love about my job, is getting into people's heads like they're characters that you write about, and really understanding what's the motivation here. What is my obligation to them? When do I support and when do I push?
It's an interesting inversion because, when you and I first started talking on the podcast and when you wrote your book, so much of the conflict was around overtreatment. Oncologists prescribing just, round after round of chemotherapy for clearly terminal cases and people not enjoying their lives at all. But now it seems like maybe that message has gotten out enough that people are going too far the other way. They're saying, oh, I don't want any treatment because this is definitely going to be fruitless. And I want to have just this kind of, very peaceful death on my own terms. And that has been sort of, glorified, and people are overly optimistic about that the way they have been traditionally around chemotherapy, for instance.
Yeah, I will emphasize that these cases are kind of in there's a pretty small minority of people who are very, very extreme in their decision making. I think what keeps me in business is making sure that various doctors in various specialties don't overtreat, or at least understand and articulate to me and to others what are their own goals of offering therapy after therapy. So you explore the patient goals, but I have increasingly moved into the realm, and I've done this all my life, or not all my life, thank God, but in my career, but understanding the motivation of the physicians offering these things and trying to understand what are they hearing when the patient talks to them about their hopes versus what I'm hearing. And then if I hear completely different things, which sometimes happens, then how do you reconcile what the cardiologist or oncologist or nephrologist is hearing with what the patient is telling me, especially if they're telling me, I don't think my specialist physician listens to me. And yeah.
Well, I was going to say, can you describe that disparity? Describe how an oncologist would answer that question. What is the patient telling me versus what the patient is telling you?
Yes. So I recently had a case of someone who was in his 30s with metastatic esophageal cancer. And, he had some pretty terrible complications from it. But he had told me that he didn't feel like his oncologist really answered his questions or listened to him, and that a lot of what he was fixated on was clinical trials. And so the majority of what they talked about was, if this doesn't work, here's what I have next. And the oncologist felt that he was listening to the patient and that the patient was telling him he wanted to fight at all costs. And I wasn't in the room, so I don't actually know what was said and what was heard by both parties. But when I hear such a vast disparity, it really makes me wonder, how are we hearing each other? What is our agenda going into an appointment? We're taught in medicine, or especially in palliative, to make ourselves seem less scary, to say that we don't have an agenda. But everyone has an agenda when you're meeting with a patient. You have an interpretation of your responsibility to them. You are going in, if you're like a surgeon and what you do is surgery, that is naturally how you're inclined to steer the conversation. So it's not even necessarily some of these specialists' faults, but it does raise issues when we're trying to navigate next steps with a patient.
I'm sure that we've talked about this in our previous conversations, and people can go back and listen to those episodes. But, when you talk about the agenda of the oncologist, obviously they feel a responsibility for their patients and they care about their patients. But there's also data and, the reputation of that cancer center. And if they can show that, people with this particular diagnosis live 5 months longer or even 5 weeks longer at this hospital as opposed to another one, that is driving them, is it not?
I think that is sometimes part of the motivation. It's hard to get, people won't necessarily say that explicitly. So that's also what's so fascinating, is what is said and what the subtext is. And so, for example, if I'm in a family meeting and oncology or whoever is offering a treatment and says that studies show someone will live an average of 5.8 months longer or something, one of my questions is always, is the person before you someone who would have been included in that study? Would they have met the criteria for the study? Because from a logical perspective, we have to interpret data based on the person in front of us. And if the person in front of us would have been too sick to get that treatment, then the results don't apply to them. And so that's something that I, encourage even listeners to think about when something is offered. Consider whether you or the person you love would have been admitted to that study, because that's the best way to extrapolate the results. So if someone is well past the point of being able to qualify to if they wouldn't meet inclusion criteria for the study, then how much can we really apply those results to them? So, this is something I'll ask the oncologist before the family meeting, or sometimes in the family meeting. If I can tell that the family has something on their mind, I might ask a question, and sometimes I play dumb, just to kind of get that question out in the open. And it's never to back my colleagues into a corner, or never with any malintent, but it is more, again, what is being said and what is not being said. And I think that's the other really interesting part of my job, is exploring the text and the subtext, just like you do in writing, right? You're writing about something, but you're leaving certain things out for a reason, because that's the subtext of everything. That's what makes it art.
Right. God, that's such a great point to ask that question. Would I have been included in this study if it had been available, if it had been being conducted while I was sick? That's such a great point. Can you talk about why we're seeing younger people with late-stage cancers? I mean, I know you and I have talked about this privately, and you don't have any answers. Nobody has any answers. But describe what you're seeing, the scope of it, and if you have any theories as to why this might be happening.
So I'll be honest with you, Meghan, when I am on service in the hospital, and I only see patients who are hospitalized. So right now, I don't see anybody who's well enough to come to clinic. So everybody I'm seeing for symptom management or for goals of care discussions are often pretty sick. I work at UC Irvine at the hospital in Orange, California, which is a safety net hospital. So it's kind of the county hospital for Orange County. So I mention that because I think it's important to couch what I'm going to say in the context of where I work. I often, when I am on service, have weeks where almost everybody on my list is in their 20s, 30s, and 40s. Almost every week. And it has become so routine that it no longer takes me aback. And I finished my training 11 years ago. And 11 years ago, if someone was in their 30s, like I have a chapter about this in my book about a woman dying of AML in her 30s and just how distressed everybody was, the family, the team, the patient who was awake but intubated on dialysis. Our team, me, I mean, it was just like that. She was around my age at the time. And part of the reason for all the distress, I mean, the situation was distressing, but the fact that she was in her 30s made everything worse because a lot of the bias is that she hasn't yet lived a full life.
Right.
So we need to help her have as much time as possible. And that's a big assumption on our part. Number one, what is a full life? Number two, how does that have anything to do with age? And number three, making those assumptions shuts her out of a conversation about her own life.
Right. I think we talked about that last time, that actually younger people are suffering more because physicians are just barreling through, assuming that giving up is somehow like just not an option. In this case, is it acute myeloid leukemia? Is that what you're referring to?
Yeah.
Okay.
There you go.
When you describe these patients in your hospital now, do most of them have cancer, or is it other things as well?
Most of them have cancer. And I had a 23-year-old with a horrible lymphoma who asked me, are there other people that you see who are like my age? And I said to him, I'm going to be honest with you, the majority of people I see here are close to your age or maybe 10 or 15 years older. But there's a lot of people in their 20s who are suffering like you are. And it's awful. And none of you deserve to be going through this. But he was kind of taken aback that he wasn't exceptional on my list. And yet he was also comforted by the fact that he wasn't exceptional, that he wasn't the only one going through this. And so, I had the case or a case of a 30-year-old diagnosed with horrible and very aggressive pancreatic cancer who was about to be a father. And thank God, his daughter was born, I think 2 weeks before he died. And he was able to hold her and be with her. But, the devastation for the family and for all of us, because this was a truly I've seen a lot of patients in my training and career, but there was something like very deeply special about this man. He was wise beyond his years. He was incredibly kind, even when he was writhing in pain. He didn't want to seem demanding or that he wanted opiates to get high. Very just a really exceptional human being. And many of my patients are, but I think, there's a lot of theories about why younger people are facing this. Some of it has to do with instability in certain cell lines. Some of it has to do with exposures to plastics or food that's got a bunch of artificial stuff in it. Environmental exposures and nutrition are some of the leading theories about this. And so when I see people in a county hospital who are living in areas that they're way more exposed to toxins than someone living in Bel Air, and the nutrition they're getting is not what the person in Bel Air is probably getting, it makes sense in a messed up way that this is the population that I see. But I saw it when I was at USC taking care of very different patient populations. I saw it at UMass. So across my jobs, it has become a bigger and bigger trend. But I think at this job, I'm seeing it more than I ever have before. You even see it on our in-training exams where you get a question, or my maintenance of certification exam, where you get questions to answer, and the stem of the question, patients are described as being younger and younger.
Wow. You say you're at a safety net hospital, a public hospital, county hospital. So are these like people who are extremely poor? I mean, you say it's a range, of course, but like, are we talking people who have just had really, really difficult backgrounds, people who've been living on the streets, for instance? Like, what is the range?
Yeah. So I would say it's kind of middle class to lower middle class is what I'm seeing. I do see people also who are professionals, so it kind of ranges. But for the most part, I would say I'm seeing people who are holding down multiple jobs to stay afloat. And a lot of people, a lot of immigrants, a lot of people, and some people who are afraid to even come seek care now because they're Latino and because ICE is doing what ICE is doing. And so it's very psychosocially complex in addition to being medically complex.
Okay, I just want to pause on that and make sure that we clarify this. And I know you're speaking anecdotally and nobody has the answers to these things, but are you suggesting that you have seen patients who say, I don't come into the doctor because I'm afraid of leaving my house because of ICE raids? I mean, this is a relatively recent phenomenon over the last 4 or 5 months or so. So I just want to be very crystal clear. You have experienced that kind of anxiety in patients.
From a handful.
Wow.
Yeah. And I've also seen a lot of patients who their first language is Spanish, but they want to speak to me in English. And I speak Spanish fluently, but I have not seen that before either too, where people want to almost make it clear that they speak English. And I don't know what that's about exactly. I don't want to link it to anything because who knows, but it is something I've seen recently that I don't know how to make sense of.
It's been over 5 years since your book came out, That Good Night. You've been on the circuit all over the place talking with people about these issues. How much has the discussion changed since then? Do you find that people are more willing to talk about this? Is there a relief that it's being talked about? Is it being talked about in a way that is maybe not as productive as it once was? How are you feeling about it?
So I do think, especially because of COVID, that people were forced to start confronting death as an everyday thing and as something that was unpredictable because you don't know if you're going to get the virus. In the early days, we didn't know much about it. So if you got it and came in to see us, we didn't really know what we could do for you. And all people knew was that if you get it, and for example, you're immunocompromised, your chances of dying were much higher. And so I do think COVID forced more discussions about the basics, like would you want to have a ventilator? Would you want to be on a ventilator? Would you want a trach? Would you even want to go into the hospital knowing that, like for anything, knowing that there's a lot of sick people there? And I do think it forced a bigger conversation about grief. And so I think that there were some, I don't know whether to call them blessings, but slightly more positive outcomes from the pandemic was that I do think there was a heightened awareness that if we don't know what someone wants and they go into the hospital and they have a sudden change in condition, which COVID is known for, that you can be okay and then you can be tipped over the edge, then you don't want to be scrambling to know what to do. And so I do think there's been more openness. I think other movements like physician aid in dying has opened a lot more conversations about how people want to die. I think, things like death over dinner and those sorts of attempts to have social gatherings where you talk more openly about this in the theoretical sense, I think there's a lot more openness to talking about and considering that. But as I said before, I think that something I've also noticed is people can say a lot of things in theory, but when it comes to down to the wire, what are you actually going to choose? And people don't always go for what they say they're going to go. I see this especially around CPR, which, as you know, is one of my favorite things to talk about in a sick way. But, there's a lot of people who say, no, I would never want that. I want a DNR tattoo. Then you get to the point where someone is in a crisis. They haven't filled out paperwork. They've just kind of said these things. And sometimes people are terrified and they want to be intubated. And they say, give me a chance if my heart stops. So you never act. This is why I think a lot more about the theories and the theoretical questions we pose to people and the actual outcomes. And sometimes they're the same, but sometimes they're not. And it's worth acknowledging that what we think we want may not be what we actually get or desire. And that, the cases that I talked about with the man with metastatic colon cancer saying, being very defiant about what he wanted, but changing that after discussion. I think 11 years in, I am much more drawn, you're going to love this, to the nuance than like the things I believed coming out of fellowship, which is that, a good death was a good death at home, for example.
Mm-hmm.
Like if I couldn't achieve that for someone, then it was my fault. If people say that they want to be DNR and want a tattoo, get it.
Are you talking about an actual tattoo here? You could get this? What do you mean?
Oh, yeah. There was a case, I believe in Florida, where there was a man brought in. I don't remember the circumstances. I think he might have been found down or was cognitively unable to make decisions. And he had a big do not resuscitate tattoo. So the ethics committee in the hospital, I think it was on his chest, and the ethics committee in the hospital, like the people taking care of him didn't know what to do. Should they resuscitate him or should they follow the tattoo?
It wasn't like signed by a judge or something. I guess it's not enough to just get the tattoo. I mean, he must have been thinking about this a lot, or maybe it came up for him before. Like, what would possess somebody to do that?
Yeah. So the ethics committee debated it, and I believe the outcome was to respect the tattoo.
Unless it stood for something else. Maybe it was initials of his loved one or something. I mean, how do we know that DNR? It could have just been something else.
It was spelled out, but I'm a little fuzzy on the details, but this does happen. And so all of this obviously made the rounds in our field, and a lot of us were thinking, well, what would we do in that situation? So the nuances of human behavior and what people actually do when faced with the enormity of death is not always what they say they're going to do, or not always and sometimes it's the opposite direction, where people are like, I want everything done. And then they're facing this and they're feeling like, I've been through multiple treatment lines. I can't breathe. Why would I do any more? And so you never know when the realization of what they're facing is going to happen, and then the subsequent decisions that are going to be made.
My understanding is that the data shows that people who are interested in, being able to end their own lives or physician-assisted suicide, that kind of thing, if they get the medication and they just have it, that in and of itself is comforting enough. And I don't know, a significant portion of people who obtain the medication never use it.
Exactly. I think people want the safety of control. They want to know that if it becomes too much, that they have that off-ramp. And I've definitely observed that in my practice. I haven't gotten any requests recently for this, but in the past, when I have, a lot of it was because, their pain might be controlled now, but if it gets really out of control in hospice or we can't help them, or they perceive that we're not doing enough to help them, then they want to know there's another way. And some pain, Megan, is very humbling. Mm-hmm. Some pain is really hard to control. And I used to think, we're the experts in pain management, but I have had situations where someone's pain is like, no matter what I do, no matter what the dose is, no matter how many medicines, I can't make a dent in it. I had a guy on a dilaudid PCA, which is a patient-controlled pump, ketamine, methadone, like a bunch of things. And there were particulars about why I think this happened, but just we could not get him comfortable. And that's horrible. That's when you feel like a failure. Like I've decoupled death and failure. I don't think that that's my failure, even though you kind of feel like it is in your training. But I think when I fail to do my best, or not fail to do I do my best, and I feel like I have still failed someone because they're still suffering so much, that is very hard for me. That's maybe the equivalent of a surgeon taking someone to the operating room and having a bad outcome.
Mm-hmm. What is your relationship to somebody wanting to end their own life? I mean, do you actually prescribe that medication? Are they referred somewhere else? How does that work?
So in the past, the policy I wrote for USC when I was there, it was made very clear palliative care does not prescribe this, because I think that that doesn't serve our profession well to be even more saddled with this idea that all we do is help people die. But the person who was treating the main disease that the person was going to die from was the person who should be prescribing the medications. And if someone comes to me and wants to do this, I think it's, again, really getting at the exploration. Where is this coming from and why? And sometimes I have had people say, I can't live with this pain. So we talk about taking a stab at treating the pain. And if the pain's treated, sometimes the request goes away. If the pain's treated, sometimes people want to go back to treatment for their cancer or for whatever they have going on. So it's remarkable what just treating a horrible, life-altering symptom can do.
Do you ever have people who say, I'm alone, I live alone, I don't have any family, I want to be able to end my life on my own terms by myself?
I have definitely had that. I had somebody come up to me after a talk I gave, basically asking me this question, that should people who are alone and have no family to take care of them, and they get a terrible diagnosis and they don't want to withstand the indignities of being sick and having to be taken care of, do you think those people should be granted access to medicines to end their life? And it was kind of a disorienting moment, because I think the talk was a lot about writing and being an author and being a patient. There was this
it's a natural segue, writing to thinking about dying. It's kind of 6 of one, half dozen of the other.
There you go. So I said to her that I think it would be very sad if that day ever comes, because you want to feel like there is still a way to give people the support they need, even if it's not what they imagined it to be. But I think there is a lot of despair, and there's a lot more disconnection and loneliness and isolation than there was when I was in training. So you see it a lot more. You either see people who have no one to take care of them demanding every treatment done, and then you see people who are like, I'm alone, I can't handle this, I don't have the money to pay somebody to handle this. So I don't really know that I want to go through any of this. I would rather just take care of business. And to me, that feels like society is failing all of us because of this disconnection and isolation. It's almost like the terminal stage of loneliness, that when you're facing loneliness at the end of your life and you just find life not worth living anymore, should you be given the means to end it?
See, I don't think of it that way. So as you know, I live alone and I don't have a lot of family, and it works pretty well for me when I'm healthy, but I worry a lot about what will happen when I get sick. So I actually take great comfort in the idea of having this option, whether or not I would actually exercise it.
Yeah.
And I actually wrote a lot about this in my most recent book, The Catastrophe Hour. The title piece,
Yes.
it's actually about real estate, but I talk a lot about imagining the house I want to be living in when I die, and even ridiculous things like, oh, I don't want to live in that house because my hospice worker won't have anywhere to park. Like, how am I going to be carried out of this structure when I'm dead? Like, is there a lot of stairs? I mean, it's silly, but there's also like a real, I think frequently about what I will be looking at in my final days and hours. And it's a serious question. And so I really like the idea of being able to control this. And I don't think it's depressing, actually. I find it comforting and even inspiring, if that doesn't sound too weird.
Oh, no. I mean, I think if you had a diagnosis where you had 6 months or less to live, that option, I think it's absolutely important to have that option. The way I was interpreting your question and the way that this woman posed to me after my talk was, if you don't even have a condition that's going to take your life, should you just
I see.
allowed to say, listen, I know I'm declining. I don't want to live this way and I have no one to take care of me. So why not have an option as an out? And that to me is a very different question than what I fully support your answer to, which is that if you're sick and you know death is near, why drag it out? Mm-hmm. For some people, that is absolutely the right choice, or just knowing that you have it in case things get really bad. But I think, and in Canada, there's been some interesting reporting, like the piece in the Atlantic, which ran recently about medical aid in dying in Canada, which much of that is euthanasia, where a physician is injecting a patient with medicines with the explicit intent of taking their life under certain circumstances. And there were reports in that article about people kind of feeling like they have nobody left to take care of them. And maybe this is what they felt pressured to do because of that.
Yeah, the whole situation with MAID, medical aid in dying in Canada, I find very confusing and elusive. I mean, we hear horror stories and we hear people with a sort of political agenda talking about it in a certain way. And then we also hear, well, that is a political agenda. Don't believe it. But I mean, there are pretty credible reports that even people who aren't sick at all, they just can't even afford housing, or they're just really just destitute, are being, quote unquote, offered MAID as a solution. I don't know how much of the discourse is coming about because people want to talk about single payer healthcare and make a point about that. Well, if we're going to have single payer healthcare, this is what's going to happen because the government doesn't want to fund expensive late stage and end of life care. I don't know. It's a big confusing mess.
It really is. And, some of the stories in that piece, like somebody, I hope I'm not misremembering, but somebody with like an early stage breast cancer, I think it was, the surgeon or somebody brought up MAID as an option. And I think the reason why was they said, well, it's important for people to know all their options, something like that. And I don't, as someone trained in ethics and palliative care, like I don't believe that should be presented as an option at that stage, unless the patient asks about it. And you can, again, explore, why are they interested in this? What does it mean for them? Like, how does it weigh against the other options presented? And I was initially very against aid in dying when the bill first came up in California, because I think by then I was like 2 years into my practice or something, like 2-3 years. And I remember thinking, well, people don't even have access to palliative care. Why are we not focusing on that? And I still believe that. But I've also been humbled by situations where, again, the pain was beyond my control, no matter what I did, short of essentially palliatively sedating somebody. So I have been open to changing my mind on things, but I think with the way medical aid in dying is conducted in Canada, from what I know, and again, I'm not the expert on it, but I could never imagine myself participating in that.
Yeah, if anybody's listening that knows of any experts to talk with about the situation in Canada, please let me know, because I've been on a mission for the last couple of years now to figure this out, and it just seems to be more and more of a labyrinth. Speaking of being alone, what can people do to ensure that if something happens to them, if they get into an accident, if they are, in a situation where they can't make a decision on their own, but they don't have anybody around them, that things go the right way? I mean, even leaving the house. I mean, I have to say, like, every time I leave the house to go for a run, for instance, like, I don't have my ID with me or anything. Like, sometimes I'll just put a Post-it in my pocket with like a friend's phone number or something, or like just even my own name in case I get hit by a truck.
Yeah.
But that doesn't seem very efficient.
Well, you could always tattoo your whole advance directive on your chest.
I could.
Just kidding.
Or just on my face,
Just on your face, exactly. Yeah. So I think that having an advance directive is really important. Having somebody in your phone that sometimes I'll put someone under ICE, which now means something,
Oh, yeah, exactly. Be careful with that.
Exactly. But I'll put in case of emergency, and then I'll put someone's phone number in there. I think I do a kind of what you do, which is I have in my wallet behind my ID the names of the people that are my emergency contacts. Because if you're in an accident, we do go through your wallet to try to figure out who you are. And if you come across something like that, you're like, okay, this is important for us to know, like, we can make these calls. And I think, like, really thinking about who you want involved in your medical decision-making, as well as who you don't want involved. Because I see this so much. I know it's a stereotype, but it's a stereotype for a reason, that some family member or some former partner, some child, somebody can come out of the woodwork, not having seen the person in years or been involved in their care, and start to take over the discussions and kind of bully other people who have been there into certain decisions, whether it's we need to let him go or we need to go nonstop till the end. CPR and everything. And so I think that's something I always tell my patients too, is when you're filling this out, I want you to think about people you don't want involved. Remember that you can revise this, but if there are people who you think under any circumstance, no matter whether, if your relationship changes in any way, you still would not want them involved, please write that into your advance directive. And I think, like, having conversations with friends about what you and what they would want in a devastating accident, because that's kind of what you're getting at, that if something happens, who's going to know what to do? And I think there are ways of talking about these things and framing them as an act of love, not as coming from a place of fear. Because I think when you're talking about, how do I want you to be my voice when I am dying? That is an honor and such a powerful thing to ask of somebody. That's a big responsibility. And, like, I don't take it lightly for the people who have asked me. And so trying as much as you can in these conversations, whether it's with friends about what you would want them to do in an accident, or with your doctor or somebody, kind of saying, I want to talk about this because I love you and this is an act of care, as scary as it might be. Because I think reframing it that way powerfully shifts the dynamic. That it's not just about, oh, I don't want to talk about it because I can never imagine letting you go. It's more, this is the price of love. Loss is the price of love. And I want to tell you what that means and looks like to me. So I'm not leaving you in the position of guessing. Because that's not an act of love.
Right.
That's of avoidance.
It's also an imposition.
It's an imposition. And I ask people, I try to bring the person into the room when I'm having these discussions, like, if he suddenly left the ICU and was able to sit here and talk to me himself and listen to this conversation, what do you think he would say? What questions do you think he would have? What fears and worries do you think he would have? Try to get them out of the way so that the person's actual voice can be channeled. Like, there are ways I can do that. But if the person has actually said something already, then it's even more powerful. The other thing I'll try to do, and recommend this as a technique to get these conversations started, is I'll ask my patients, like, tell me about the relatives you've lost and how they died.
Mm-hmm.
I try to get at their interpretations of what a person who died well looks like and what a person who died badly looks like. I try to stay away from the terms good death and bad death because I think they're so binary, but who died well is a different question. You can die well in the ICU. You can die well with us taking care of you in the hospital. That's not a failure. That's just how things panned out. And like I wrote about in the Times piece, we don't know what our bodies are going to allow us. We don't know what's actually going to happen at that time. All we can do is try to live in them now and understand them and respond to their cues so that we get help when we need it and don't push it off because we're waiting for retirement or something else. And it's the same thing when someone is dying. That a lot of times families will tell me, I feel like I couldn't even grant him his last wish of dying in his bed.
Oh.
And I have to reframe that and say, none of us had any control over him suddenly getting horribly septic after his last chemotherapy session because he had done well in them before. But this is what death does. This is what life does. It just shows up. And we have to deal with them, with the consequences. So it's not your failure. It's what his body showed us its limit was in this way. And it's an honor. And again, I tell people it is a privilege to walk people to the riverbank and to be there in that sacred moment. Because all of this is sacred. Death is not a medical event. Death is a sacred event, and it always has been. And so taking that guilt away from people and reframing it as we have no idea how a disease is going to behave, but he can die with dignity in the ICU. That is still possible.
That's really a powerful way of framing it. I'm sure I've asked you this before, but I'll ask you again. How do you think about your own death, and how do you incorporate it into your sense of sanity? Because I sometimes get spun out on this. Like, oh my gosh, anything could happen at any time. They won't know where I am. My dog, I'm going to leave. I'm going to get into a car accident and my dog will starve. That horrible story about Gene Hackman and his wife, and she was sick and he had dementia and she died and he was wandering around in the house and their dogs, they were found months later. Just like absolute worst case scenario horror story. I, for one, get that kind of thing in a loop in my brain sometimes. I go through phases. Do you struggle with that?
So I think that I have from when I was a kid, right, I was taught that mortality is coming for all of us and that uncertainty, and this is more what I have learned in my medical training, that everything is uncertain and unstable. And that's like the nature of life. I'm not some guru who has it all figured out. I will tell you that. But I think that I have an everyday kind of conversation with myself about mortality. Like if I'll take my dog on a walk, I love my neighborhood and there's people whose gardens are just unreal. And you see like bushes of roses where all the petals are on the ground or the flowers have fallen. And I'll think to myself, even in death, they are so beautiful. And I have this intentional discussion with myself. I think it's part of the reason I've felt weird grief this fall, which I love the fall, but this year it really snuck up on me in a way that made me even more aware of how fast time is going. And so I think about my mortality and do an assessment of like, am I really living the life that I want to live, and why or why not? I don't get worried about being found in a state of like absolute decay, but I get what you're saying, and feeling like anything can happen at any time. I think especially in the world we live in now is something I think about a whole lot. And I kind of have to say, I acknowledge that that can happen, but I also acknowledge the things you least expect that might be more positive can also happen. And that's the nature of uncertainty, that the bad things can happen, but so can the good things.
Well, Sunita, I love talking with you, and you are a fan favorite. I guess people want to hear about death. It's always a popular topic.
It's like going to happen to all of us. There's literally no way out.
You think? Really?
Oh. I know, right? Maybe the crazies in Silicon Valley will invent a way to live forever, which, by the way, that sounds like the most unappealing option in the world. But maybe that's another conversation.
Yeah, that is another conversation. And I wonder if a sort of collective fear of death is driving some of these advancements. It's perplexing. It's not really perplexing, but it would be worth exploring. But sure. Yeah, I don't really need to be, I don't need to be transhumanized or anything like that.
Me neither.
All right. Well, Sunita, thank you so much for everything that you're doing, and thanks for coming back on.
Thank you for having me.
That was my interview with Dr. Sunita Puri. She is an associate professor of medicine at the University of California, Irvine School of Medicine, where she is the director of the Inpatient Palliative Care Service. She's also the author of That Good Night, Life and Medicine in the 11th Hour, and she's contributed to the New York Times, the New Yorker, and the Atlantic, among other publications. This is the Unspeakeasy podcast, part of the Unspeakeasy empire, larger project. Next year, we have a number of retreats coming up. We're going to be announcing them soon. Possibly we already announced them, but just to be safe, I'm going to say we're close to announcing them. We're going to do a co-ed overnight retreat, a 2-night, 3-day retreat in the Hudson Valley, most likely next fall, probably October of 2026. Also going to do a women's writing retreat in the Catskills that I'm going to be running. We'll do a women's retreat in Los Angeles and possibly another one in New York. I'm going to be teaching a Zoom writing workshop early next year. To keep informed about all of this, go to theunspeakeasy.com and get on the mailing list, or just check the website. Also, I'll keep talking about it here on the Substack and elsewhere. I will be back next week with another super nuanced guest. Thanks for listening. See you then.